Welcome to the Human Factors and Ergonomics Hub, a series of educational podcasts that showcase the connection between human capabilities and good work design, brought to you by the Human Factors and Ergonomics Society of Australia. Hi everyone, we're back on the HFE Hub, and today I'm chatting with Mary Patterson. Mary is a pediatric emergency medicine physician in Florida. She was the founding medical director of the Cincinnati Center for Simulation, Education and Research, and she is the past president of the Society for Simulation in Healthcare. Well, hello, Mary. So great to be chatting with you on the HFE Hub. Welcome.
Well, thank you. Thank you for having me.
That's a pleasure. Tell me a little bit about yourself and what you do.
So I am a pediatric emergency physician, and so that's my clinical practice. For the last 4 years or so, I have been chairing the Department of Emergency Medicine at the University of Florida. And I just stepped down from that role, and I'm going back to my first love as the Associate Dean of Experiential Learning, which largely involves simulation work. And I'll be doing that beginning next month.
Okay, so you're working in simulation. Are these the only kind of projects that you work on at the moment?
Well, no. Been very interested in combining my interest in resilience engineering and safety 2 with simulation work. So myself and the team that works in our simulation lab have been working to adapt or adopt resilience engineering principles in our simulation work, and we tend to do a great deal of work both in situ, which is in the clinical space itself, rather than in a lab. As well, we do a lot of system analysis and looking at processes and how to improve those. So there's a nice alignment with resilience engineering and safety 2, as with our simulation work, along with our simulation work.
Okay, for those listeners in the podcast who don't know what safety 2 is, could you tell us about that?
Sure. So this is a concept that originated with Eric Hochnagle quite a number of years ago now, but it's the idea that in safety, we spend so much of our time looking and studying the things that have gone wrong, and when in reality we ought to be spending more of our time looking at what goes well and why it goes well. So it's really an interest in the normal or mundane, the everyday, and why so much of that goes well. And that includes both, of course, healthcare, which is high risk, but also other high risk industries and areas, fields, domains. So that's where it came from. And resilience engineering is, again, very safe, very closely related to that, with the idea of how systems, people, systems, teams are able to be adaptable, what supports adaptation, what supports their abilities to respond to disturbances, perturbations in the systems in the everyday work. Because we all do it, especially in areas like healthcare. We're constantly adapting. And how does that get supported? How do we make that doable? And sustainable for the individuals working in the system, but also the people who receive care and the system itself.
So do you use simulation for the Resilience Engineering Safety 2 project?
Yes. So one of the things we've started working on, our team altogether, is a number of things. So one of them is using something called the Resilience Assessment Grid in our simulation work. And this is a tool, again, developed by Eric, that allows us to use simulation to look at a system, look at a process, even looking at a new process. And we then use the frontline healthcare workers to tell us what aspects of this system are working well, what aren't, where is there a need for more support, or where does the process need to change. And over time, we can do these, it can be done as a survey, but it can also be done as a focus group kind of an idea, to tell us where we're making progress and where we aren't. And this can actually be graphed so that we can compare over time what aspects of the system are, if you will, be having a deeper bench where there's more resources, it's more adaptable, and what areas maybe, for example, are becoming more brittle. If, for example, resources are removed and the system is less adaptable, more brittle. And it's based on the frontline healthcare workers' perspectives on this. And again, frontline healthcare workers are very important, both from a RE or from a safety 2 perspective.
So I'm familiar with simulation labs, but just tell me how you use simulation in these projects.
So for the most part, these types of projects are done in situ, and that means that we're doing them in the actual healthcare environment. So that may be a particular clinical unit. It may be an operating room. It may be the emergency department. Recently, our hospital stood up something called a mobile stroke unit. So the idea of this is it's a looks like an ambulance, a large ambulance, but it actually contains a CT scanner and is staffed by typically a paramedic and a advanced practitioner like a ANP, an advanced nurse practitioner, or a physician's assistant. And what happens is if the medics are out in the field and maybe some distance from the hospital, and they identify that somebody may be having a stroke, then the mobile stroke unit, which is based further away from the hospital, can then be sent to that particular location, and a CT scan can be performed very quickly, and that can be reviewed by a neurologist via a telemedicine hookup, if you will. And then depending on what that shows, the individual may receive, if it's felt to be an ischemic stroke, that individual will then receive clot-busting drugs that much sooner. The goal is to get these clot-busting drugs administered as quickly as possible. So this was something that the hospital wanted to begin. And they had some ideas from looking at other places, how it had been done in other places. So some protocols and different standards were developed, but they hadn't really been tested. And we spent, our team spent a week simulating this with the people that would be staffing it and doing things like testing the telemedicine hookup or understanding how roles and responsibilities were partition divided between the people that were staffing the mobile stroke unit. So that was an area where there was an idea. It had been done in other places, but not really tested in our context. And so in a week's time, we made some significant changes to the processes and procedures that reflected our context, but as well, the individuals who were working on that mobile stroke unit were part of the process of creating and improving, co-developing the processes that would be used. And that went really rather well. And so as the mobile stroke units expand across our system, a couple of weeks ago, our team was in another part of our healthcare system, again, training the mobile stroke unit there. So they were a couple of hours away from our main academic hospital, working with the folks that will be running the mobile stroke unit there. So that's, I think, a good example of how we marry the ideas of the resilience engineering with simulation.
Yeah, that's a fantastic project. My question is, tell me something that you may have learnt from that project that you weren't expecting to learn, or something that kind of blew you away a bit when they were running through the protocols.
Yeah, so it happens quite often that we're working through a protocol, and what looks good on paper, or in somebody's mind that hasn't been doing it, especially if the protocol does not include frontline healthcare workers, and sometimes even if it does, when we work through it, we find that there are elements that just weren't considered, or they were just, and not obviously on purpose, but just that people were not thinking all the way through, and the cues that are present when one is actually doing something as opposed to when one is just thinking about it. So that's the beauty of doing it in the clinical environment. And we've had those kinds of things happen quite often, where, for example, one looks at for example, the medication, and while there may be an idea or a standard that medication may not actually be, for example, available in a particular setting because perhaps it requires refrigeration, or perhaps it is comes in a different concentration than what is the standard. Or there, as I suspect we have many drug shortages right now, and we're constantly substituting. So the drug that might have been available 6 months ago when this was written, when the protocol was written, may now be available only in a different concentration or something along those lines. So there are those kinds of things. We sometimes also find out things about where there are gaps, for example, in knowledge, that there's an assumption made that a certain kind of knowledge is held by the people doing it, and it may not be. And again, that's not to be critical of the healthcare worker, but it's to identify that, perhaps the equipment has changed, perhaps the medications have changed. Maybe this individual just never was trained on a particular thing. So identifying these training and knowledge gaps is also really critical. And we find that quite often. And sometimes it's a choreography thing. And what I mean by that is we were doing some work on what's called ECPR, so it's extracardiopulmonary resuscitation. And the idea is that somebody who suffers a cardiac arrest in the field and meets certain criteria comes into the hospital, and if it's believed that there's a good chance that this is a cardiac lesion that's amenable, for example, to a stent or a balloon, the person will be put on ECMO in the emergency department and then go straight to the cath lab. So as you can imagine, when somebody comes into the emergency department with the thumping device on, it's quite large, and then we're going to put somebody on ECPR on ECMO. It really is quite a dance, because there's the emergency team, there's the ECMO team, there are lots of equipment that is brought into this, and it's all needs to run in such a way that people are not interfering with one another. And so working out that choreography, even though people may know what their job is, working through that choreography is incredibly useful. And in the end, especially in these time-critical procedures, really makes the process much more efficient, much more effective, and especially when minutes count, if we're not stumbling over one another, the fact that that's been practiced in the actual setting in which it's going to take place is really critical to being successful.
That's really interesting. I love the way you've described it as a dance, because there's priorities as well as just the fact that everybody's got their roles and responsibilities. Mm-hmm. What you also mentioned that was interesting, I just wanted to come back to gaps in knowledge that you identify. I just wonder how you manage that, because that's that could be potentially concerning for the person, but also a bit threatening if you're in that position.
Yeah, so one of the things that we hold very strongly is that this has to be a psychologically safe environment. And so that means that it's going to be safe for everybody. We're all trying to get better. Our assumption is that we're all trying to do better at whatever our work is in terms of caring for patients. And quite honestly, if we find one, we often find that it's more universal than just one individual. And when we identify the gaps, sometimes it's something we can address in the moment, but other times it requires a more systematic approach. And in any of those cases, we are always doing this in a de-identified manner, and in a way to assure that no one goes away feeling that they were criticized or put down, if you will. That's not the point. And as I said, sometimes, if it's something they haven't seen before or they just didn't know about. So we talk about in pediatrics, when we give adenosine for supraventricular tachycardia, for example, there's a specific way it has to be administered because it is metabolized so quickly. And if it's not administered with a stopcock, with a quick push, it won't work because it will be metabolized before it reaches the heart. And sometimes when we identify those things, that's actually quite simple because we can just, at the end of the simulation or during the simulation, we just gather the folks who weren't aware of it. And oftentimes, even if somebody was aware, if they've never done it or they haven't seen it, then quite often almost the entire team will stay behind so that we can show them and they can get the sense of how to do it. And then they can do it themselves. We show them how to draw it up, how to push, two syringes and push and turn the stopcock, and we can all do it together. And I think people feel really comfortable with that because we're such a neutral party. We're not there to find somebody who's doing the wrong thing. We're not there to criticize. We're viewed as somebody who's there to help and help make care better. And so, when we do those things, sometimes, like I said, it's very quick and we can do it in a moment. And other times we may say, we probably need to schedule a learning session devoted just to this. And then we'll do that. But it all should be in a psychologically safe way so that people do not feel that they're being criticized or that they are less than. We try to make the point with we have ground rules at the beginning of our simulation, and we always talk about, that this is a safe place. We all want to get better. And, we're not going to talk about any shortcomings of any individual or any team outside of that particular simulation. So everything that we share on a broader scale where we feel like the institution needs to work on something is de-identified.
That is so important. I was just wondering, and you've touched on it a little bit, what preparation do you give the staff for this if they've never done it before?
A couple of things. So for people who have never done any simulation at all, we typically go through our ground rules. And there's it's not exhaustive, but it does speak to psychological safety, that none of us are going to speak about anybody else and their performance outside. So I'm not going to speak about it. We ask the learners not to talk about it either. We talk about that this is a psychologically safe environment, that we want to know what things are going well, what is not, and that our goal, we make the assumption that everybody wants to get better and everybody wants to do a better job of caring for patients, and that it takes the entire team. And so one individual, might believe that their role is unimportant, but the reality is they may be the only person who hears or knows something that the rest of the team does not. So we start with the ground rules. We do a familiarization with the equipment. So if we're using a mannequin-based simulator or something along those lines, we talk about we show everybody how to find the pulses, how to listen for breath sounds, or whatever it might be. We show them what their equipment is. So if there is airway equipment that we'll be using, we show where that is, how to find it. If we're doing something that would involve a defibrillation or a cardioversion, we go over the defibrillator. So whatever equipment might be necessary. And we do tell people that the only time we're going to intervene during a simulation is if we see somebody doing something unsafe. So for example, if somebody was going to defibrillate and hadn't cleared the space. So we will obviously interfere then because, but other than that, we don't. And so we do that. We also, of course, obtain permission for video recording if we happen to be video recording, that, we have their permission to video record. That's most of what we do, I think. And obviously, sometimes we're working with teams that have done this multiple times because we've been working on a particular project with them. And so it will be a much shorter sort of a refresher, if you will, about what we're working on, and the as well around the psychologically safe environment.
You touched on something I was going to ask, but I might just develop the question a little bit. And that was, I was going to ask you do you let the scenario play out? And you've indicated if it's life-threatening, clearly you don't. Yeah. But by leaving it play out, you see what else happens, don't you? You see what other task interdependencies or variables change the outcome.
Yes. So, and we generally do. I think the other piece that will come up is, and this has been a controversial topic in simulation for a long time, does one allow the patient to die, the simulated patient to die? And my thinking has evolved on this over the years, and I've come to the point where I just don't think it's worth having a patient die in a simulation, because that's all people remember. So if the simulation has played out and clearly things are not going well, there's to your point, sometimes teams can recover. Sometimes we can give them a little bit more information, and the teams can recover. But if we've got one where it's not recovering and it's just floundering, we will in some cases just stop it at a certain point when it's just clear that we're not going anywhere with this, and people are becoming quite frustrated. But then what we'll do is do a brief debriefing about what has happened so far and what do we think is going on. And it's really more like a pause, if you will. So what we try to do then is get them to a point where they can then approach it in a way that they can problem solve. And that is a way to not have the patient die, which can be really devastating for people. But does allow them in the end to be successful, that we've paused this and they've gotten back on track. And even if it, it wasn't pretty, let's say, but they meet the learning objectives in terms of, whatever it might be. And, there was a lot of that during COVID, because it was new to everybody. And we didn't always, know what to do, quite honestly. We were improvising quite a bit. But what came out of those and simulations was this really extraordinary problem solving that was done jointly by the healthcare teams and the simulation team. And those were then contextualized to various units as we, worked our way through the hospital, and as new problems, came up, and that sort of thing. So, and also as we gain more knowledge, of course. But that there was this really, because sometimes the goal wasn't, to save a patient per se, but it was around how are we going to intubate a patient successfely and avoid contamination, and what's the minimum number of people we need, and what's the equipment we need, in those kinds of spaces. And I know everybody was struggling with this in the beginning when we were intubating early. Of course that changed later on, but we were all trying to figure it out jointly together. And even people would be talking to their colleagues in other countries that, for example, might have been hit earlier. And we would try to bring that into the work we were doing.
So user feedback in terms of after the scenario has been run and you've given people the feedback, what are some of the responses?
A lot of people who haven't done simulation are quite anxious the first time they participate. And I will say there are some people who've experienced, I'll say, bad simulation. It's been used more as a weapon. It's been weaponized for what people are doing wrong, and those individuals are often very anxious about participating in simulation, and appropriately they're concerned it's going to look like it did for them previously. If we can get somebody into one of our classes, our feedback has almost always been, it's probably 98% positive. People feel that we've met their needs in terms of what they need to learn for a particular whatever we're working on, and they want to do more of it. So if we can get somebody past perhaps a bad experience they might have had in some sort of training or professional school or whatever, they then feel really positive about if they can come to one of our, whatever we're doing in In Situ or a class that we're running in the lab, they're almost uniformly very, very positive, and they want to do more of it.
Do you use it? You've obviously indicated you use it to run through new things, new developments, various protocols in the testing area, but you're also using it for training.
Yeah, so it's sort of the idea of, formative versus summative, work. And almost all the work we do is formative. There's very little that I would say I would call high stakes in the work that we do. That's not to say it doesn't exist in the simulation world. Certainly it does. But for what we do, it's almost always formative. I'm trying to think if there's, I guess the one, like there's a couple of things I can think of where there are exams that are given by simulation. But that's not typically our team. There are, for example, the fundamentals of laparoscopic surgery, which is done by simulation. It's an exam that all, for example, surgical residents need to complete successfully and it's time bound. And they can take that exam in our center, but we're not the ones running it. It's proctored by the national residency group. And so they do exist, but we're typically not part of the summative ones or the high stakes ones.
Tell me about some of the challenges implementing a system like this.
So I think, that there are some common challenges. There always will be more demand than we can fill. That's I think it's a good problem to have, but it does mean we need to prioritize. And I think the other challenge associated with that is, we believe that what we do makes patient care better. And, for example, one example I will give is, our nurses, when we have new graduate nurses coming out of school, post-COVID, their patient care exposure, their clinical exposure has been less. And so they come with fewer skills than clinical skills than they might have had. And we run a transition to practice course for them for the first, I'm trying to remember how many months it is, but essentially they come to us so many times a month in their first 6 months, let's say, of working as a nurse. And that course, for example, I think makes a huge difference in terms of patient safety and care. So we run a lot of training that we think makes things safer. But of course, it's cost avoidance, and it's always hard to prove that something didn't happen because we did something. So I'd say the other big challenge we have is assuring resources. And I think there's sometimes for individuals who are not familiar, they don't understand why we aren't able to create a revenue stream, for example, with simulation, or why they don't understand why it's so resource intensive, because it does involve a lot of human resources as well as equipment. And so it's an expensive undertaking, albeit I would argue it's certainly less expensive than poor patient outcomes, on many levels, whether we're talking about physical or emotional or, the value of a life, those kinds of things. So I think that's the other, the challenge in institutions where, we're thinking about, as you can imagine, especially we don't have nationalized healthcare. So it's the hospital supporting some aspects of it. It's the College of Medicine supporting some aspects of it. The College of Nursing, we collaborate on some things, but they also have their own simulation program for the student nurses. Although there's talk of moving it all together. So it's all about, I think, supply, demand, and how do we resource it appropriately, and convincing others of the value of it makes patient care safer and better.
Just thinking of that value, we know that simulation is valuable in the clinical setting. We've talked about that. We've touched on that. There are benefits, though, beyond that, aren't there, to other departments in the hospital in terms of understanding actually how work is done, what we do, why we do it, and how to improve design. Have you had any wins in that space?
Yeah, well, I think, some of the things we do, because we debrief as a team and the team involves everybody, so we'll have the nurses, the respiratory therapists, the paramedics, the physicians, pharmacists, so that everybody will be together. There may be, different kinds of physicians or nurses all working together. And oftentimes it's the only time that a group like that, a multidisciplinary group, has talked about the work they have and what makes it easier or harder to do it. And so people may be unaware that, and when we have these conversations about, okay, what made it possible for you to do this? And that individual might say, well, when Judy did this, that freed me up to do this other thing, and that made it so much easier for me. And a lot of times that's the first time, or it's a rarity that somebody actually talks about their work and what facilitates it or makes it harder. And many times the individuals that are in this conversation had no idea, and they didn't know they were either being helpful or not. But now, especially when it's something positive, we want to reinforce that. We want that to be what happens all the time. So I think it's the idea of having people talking to one another who have different roles, who have different work. The work all goes towards a common goal. It also, I think, helps sometimes people who feel like their roles are not as important. It helps them understand how they do play an important part in the care of a patient and why their presence and why what they do matters, and why it matters if they speak up, if they see something that they should speak up about it. So I think a lot of what it is involved, we could talk about that. That's in some ways creating relationships. It also embeds respect for the other roles of the team, of the healthcare team. And, we have always deliberately, my partner in this work is a man named Tom Lemaster, and he and I have done simulation together for years and years, longer than either one of us wants to remember. And he's a nurse and a paramedic. I'm a physician, but we've always deliberately used those optics of we're a team working together, the simulation team works together, and that's what we want to see with our healthcare teams as well.
So that communication extends to, and there's several terms for this, isn't there? Soft skills, non-technical skills, the ability to question something as it goes. Are you finding that actually is developing with this simulation process?
Yes, especially with the teams that, it's not a one and done, certainly. But I think when we have the opportunity to work with teams over time, multiple times, we do see changes. So for example, we were working on a postpartum hemorrhage project. And this was actually, so the Joint Commission, which is a regulatory agency in the States, was mandating drills for certain maternal conditions, including postpartum hemorrhage. And so we were asked to work on this with the nurses on the postpartum floor and the obstetricians and the residents, et cetera. And when we first went in to do it, it was really, we could see the challenges they had. They had a lot of communication challenges. They had, there were challenges around the process. They had to switch from qualitative to quantitative estimated blood loss. We found some holes in the system such that, for example, if a woman lost, I want to say if her estimated blood loss was less than 500 mLs, it wasn't actually reported in the handoff to the postpartum floor. But as you could imagine, if somebody lost 500 and then lost another 500, we now have, a liter. So there were a number of things we identified as sort of gaps in the process. But the other big challenge was the communication. And I think because the nurses had sort of developed a culture, and I'm sure this was reinforced for them, where they would try to group their phone calls. So they wouldn't call about one thing, but they would call about 4 or 5 things together. And it might start with that, Mrs. Jones, is bleeding. She's bleeding a lot, but they really didn't know how to use an S bar, for example. They didn't know how to quantitate it and how to ask for and I need you to come now, or whatever. We've started an IV. We have this hanging, we've sent type and screen, type and cross, whatever. So we worked on those communications. The other piece they always had at the end was, and we need an order for acetaminophen, or we need an order for, a stool softener or something. So it was putting these really something very critical next to something that was pretty, mundane. So we worked the floor with the nurses' communication using an S bar, how to get what they wanted, how to be prepped for already have doing the things that they could do before the physician arrived, all those sorts of things. And it was really remarkable to see, because their communication did become crisper, and they were more able to provide a very clear description to the physician, and get the physician to respond to, come now, or whatever it might be. And we also, because we were measuring, like, how long did it take to get certain things accomplished, we saw the time, which of course matters, to be decreasing in terms of getting the appropriate work done, as well as the checklist that, was able to say they'd accomplished, the first 10 things that need to happen with a postpartum hemorrhage. So the communication was huge. And when the first few times we watched this, where we were doing it, we actually to ourselves said, okay, so we need to work on this process, and we've really got to work on simulation, on the communication, because the communication, nothing else will matter if we don't get the communication right. And they just had never learned how to do that.
Such an important thing, isn't it? And it's the two-way communication. I imagine that you're also addressing that with the physicians as well.
Yes. It has to be bi-directional. There has to be, again, closing the loop, making sure that what I heard is what you said, that we're on the same page, that we have a shared mental model about what's going on.
We could talk about mental models and this project, I think, all day, but I realise we have a bit of a time constraint. So my question probably is, at this point, is just to ask you, you're starting a new position. So just tell me what you can about the next project you're going to be on.
Yeah, so it's really going back to an old position, if you will. But we recently were successful in getting a grant from our state around pediatric and obstetric emergencies. So we're going to be combining the work we've done in several different projects, but we're actually going to be spreading it across our system. As in many places in the United States, there have been labor and delivery units have shut down, and as well, pediatrics is always makes people who deal with adults, pediatric emergency makes them a little anxious. So we have a grant from the state for the next 2 years, and we're going to be working on both the obstetric and the pediatric emergencies at these smaller hospitals, or these hospitals that have fewer resources, and how do they both recognize the emergency and stabilize and if necessary, transfer the patient to a higher level of care. Florida has a lot of rural areas. I think most people think of Florida and think of Disneyland, or think of the beach, Disney World or the beach, and there's a lot of rural areas in between that. And so we're looking at these areas that are within our system, the catchment area of our system, but for whom they may not have the same resources. And so the appropriate training. We've done some of this in our own system, where because certain labor and delivery units had shut down, women in labor were traveling further, and they would stop at the first emergency department they would hit Those happen to be two of our more outlying emergency departments. And those did not, of course, have obstetricians or anything along those lines, but sometimes these women were very far in labor. So we actually simulated and then created a system of training. We retrained the emergency physicians on obstetric emergencies and delivering babies and resuscitating babies. And then we also set up a telemedicine link with our labor and delivery floor so they could actually be coached in real time with when one of these patients did arrive in one of our outlying emergency departments. So those are the kinds of things that I think make a difference. And it's not, it's nobody wants to do a bad job, but they don't necessarily have the resources. So, that was, training people, again, for maybe a shoulder dystocia or something along those lines. We all learned it in school, but most of us have not had to do it for quite a long time. So retraining people, retraining them on neonatal resuscitation, testing the system for, do we have the right equipment? Do we have the newborn warmer, for example, and those kinds of things in these outlying emergency departments. So we're going to be scaling those kinds of things to these other hospitals over the next 2 years. So that's going to be probably that will take a lot of our time and effort, because we have to, go out to these places and understand what they do and don't have available, provide the training, but also, we're going to need to circle back and see how it's going and whether, it's been successful for them, or, does it still need more tweaking.
Thanks for joining us at the Human Factors and Ergonomics Hub, brought to you by the Human Factors and Ergonomics Society of Australia, where human-centred design really matters. If you like this podcast, make us your favourite in your podcast app. We look forward to chatting with you next time.